Yes.
Thank you.
Thank you.
Thank you, Governor Dean. As you know, I've long been an advocate of universal access. My concern, though, is that if we expand access, it's not going to be sustainable unless we start to bend the cost curve.
That's right.
So, and we all, most of us have some sense of what that should look like, but we're not sure, and you can't legislate those endpoints now. What do you think we could put in place now as part of this legislation that would give us some hope of an impetus towards those greater efficiencies? And specifically, do you think that this IMC proposal or the MedPAC on steroids is a sensible approach? Or do you believe that the public option could accomplish that?
I think the public option can certainly accomplish it, but not in and of itself and all by itself. I'd say the most heartening, this has been the most awful journalistic mess that I've seen in a long time, because they cover screening, but they never cover substance, and it's just a shame. One of the most fundamental substantive developments that I've seen is Massachusetts. Now, whatever you think of the Massachusetts plan, and certainly financially it's not a model you would want to follow, but only 2.5% of the citizens of Massachusetts have no health insurance. That is right on par with where a lot of European countries are. It's not on par with Canada, who just gets a card and that's the end of it, but it is on par with places like Germany and France where you have to sign up. It's an extraordinary achievement. I think if they'd had a public option, they would have done better, but they haven't. But we need not denigrate that. But the extraordinary thing about it is they know they have a big cost problem. And it's not just because they didn't have a public option. They happen to be in the middle of the worst recession in 70 years. So they had a big panel last month that got together, including everybody in the medical industrial complexes, the drug companies, the hospitals, the doctors, everybody. And the panel voted unanimously, including the doctors and the hospitals, to get rid of fee-for-service medicine. Now, here's the problem, and this is why the private sector doesn't work. You know, the problem is always talking about, well, private enterprise, private enterprise. There are two areas that private enterprise does not work as well as government. One is defense, as the Iraqi contracting scandals showed, and the other is healthcare. And here's why. It's not because there's something inherently deficient about the private sector. It's that in healthcare, the consumer doesn't really make the choice. And I don't care how many health HSAs you have. You can decide about doctor visits and save you $100 by not going if you're going to get over the cold you have anyway. But the really big expenses, I choose. When you're a consumer in health, if you're a consumer of a car, you go around and see all the dealerships and you make your deal and based on what you afford, and if you can't afford it, you get something less. If you're a consumer in healthcare, you come to me, I tell you what you want, and we send the bill to a third party. And the more I do to you, the more I get paid. This is insane. That's why you can't control costs. It's not just the insurance companies, although they don't help much with their gazillion-dollar increases that they have to show Wall Street every quarter because they're publicly held companies. It is the fact that the supply and demand curves can't work in healthcare. And even if they could work in healthcare, then you would have rationing by price, which we already have because we have a ton of people who have no health insurance. So if anything that you can do within the bounds of morality, that is understanding that in a country like this, everybody ought to have health insurance. Anything you can do in the bounds of morality to make the supply and demand curve work a little better is a good thing, and getting rid of fee-for-service is one of them, because if the use of services is flipped upside down by paying us more for doing more, then we're going to do more because the consumer's not making the choice. So if they do that in Massachusetts, that would be extraordinary. And let me just tell you, for doctors 15 years ago would have accused me of being a communist if I had suggested getting rid of fee-for-service medicine. Only the Republicans will do that now. Or what's his name? Lou Dobbs, I think. So doctors who are in primary care in the United Kingdom make more than doctors who are in primary care in the United States of America today, and they're on salary. The majority of, and I'm not here as a raving single-payer addict or advocate, as I've said, or addict either. But the fact of the matter is that under a single-payer system, the efficiencies are much greater than they are under our system, whether you like that piece of information or not, and that the majority of primary care physicians in this country now, by a very wide margin, favor single payer. That's true. That's a fact, whether you like single payers or not. That's true. And the reason they favor it is But the hassle of running your own practice and being told that you have to see a patient every 6 minutes and having your bookkeeper weeping and gnashing their teeth and filling out 1,000 forms is so great. And frankly, the insurance company bureaucrats that call you up after the fact and deny tests to patients they've never seen. Primary care doctors have had it. It's not true of specialists, but it is true of primary care docs. Those are the kinds of things that we ought to change. If you could just get rid of fee-for-service medicine, that would be a big step in the right direction, and I think that's going to happen. Because I think the people who are opposing this bill now will flip their position very shortly, because they realize that the incentives are driving up the cost far beyond the rate of inflation.
Thank you.
Next.
My question was along similar lines about fee-for-service, but I think corollary to that is, what about malpractice insurance and all the tests that are ordered
Great
defensively?
question, and I'll just be blunt about this. The reason malpractice insurance is not in the bill is because when you pass a huge bill like this, you make a lot of enemies. We just didn't need one more. And, you add the trial lawyers on top of the insurance companies and some of these other folks, and it gets to be the straw that breaks the camel's back. Now, having said that, malpractice is a problem, but it's a very hard problem to parse. Some states, it is a problem in every state for anesthesiologists, neurosurgeons, and obstetricians. And in some places, it's such a bad problem that they just have given up and they don't practice anymore, or they just go bare and have no insurance whatsoever and put all their assets in their spouse's name. And in Florida, you can do that, as O.J. Simpson proved. But even in states like mine, which don't really have a malpractice problem except for those 3 specialties, it's not that big of an issue. It does require defensive medicine. Probably it's an important factor. It's not as much as the business community says, but it's not as little as the lawyers say. It's in between. I think there is a solution, and a fair solution. My solution, which neither the doctors or the lawyers like, so it must be reasonable, is that you can't deny people a jury trial, and people should be compensated for injuries if they suffer because of malpractice. I think the most reasonable way to do it is to send every claim to arbitration. It's not binding. You have a right to go to a jury, but the verdict for the arbitration is admissible as evidence. And I think that the other thing that would be really great for malpractice reform is something that conservatives hate, for reasons that are not clear to me, which is comparative effectiveness research. The thing about that, comparative effectiveness research basically looks at different things that are done and decides which ones work and which ones don't. And it's factual. It started 30 years ago with Jack Wenberg at Dartmouth, who discovered that women who lived in the southeast were 3 times as likely to have a hysterectomy than a woman who lived in the northeast for bleeding. And the results were no different. That is, the morbidity and mortality didn't change. So obviously, 3 times as many hysterectomies were done in one region of the country without improving the result. Well, it's pretty obvious that you begin to have to pass that information around. People make different decisions. Well, now, of course, we know a huge amount about which devices work, which ones don't, which drugs work well, which ones. The reason that stuff is important for malpractice is if you do that kind of research and you discover what works and what doesn't, ultimately, it results in something that doctors also resisted, but much less resistant now, a national standard of practice. And once you have a national standard of practice, it's true that doctors can't quite be as cowboyish or cowgirlish as they once like to be. I can do anything I want. It's also true that you can take that standard and show it to the court and say, I did every single thing in this national standard of practice, and that ought to be an absolute defense against the fact that charge that I committed malpractice. So I think comparative research, it helps save money, it saves patients unnecessary procedures, and I do think it will ultimately protect doctors against unreasonable suits.